examination is skin tight at 5 o'clock position. Rest is on the
Okay, cesarean sections, what does that tell you?
There might be ideas and difficult to cross the
Okay.
banks. That was.
Comorbidity?
She is diabetic and hypertensive, and she is on oral medication.
Okay. So is that anything contraindicative of giving her sedation or pain relief? No? Okay. So what level of sedation and pain relief are you going to give? Expecting that you now know she's had cesarean sections. You're going to give, what are you going to do?
Cesarean section doesn't affect the.
The last lady who we did who had cesareans was very sensitive.
Yeah.
So are we going
We
to...
will have to increase the dose.
Are you, what would you normally give? What do you want to give?
We usually give the 2 milligram dormicum and 2 milligram of lalmin.
Well, I agree with that. I wouldn't give any more than 2 and 2.
Yeah. We'll give the 2 milligram dormicum and 4 of the. Mr. Wasim.
Wasim. How you doing, Wasim? It's Paul. Are you? Huh? Hello? Is it not? Hello, Janet. Are you in there on your own? She is alone. Okay, so Rima. Rima! So what I'll do, when we start the test, when we have the scope and everything, I'll start the stopwatch. We'll have 30 minutes. Yeah. No worries, my friend, no worries. So once you've got the tube in, I'll start this and we'll...
Look for the time.
Yeah. So don't worry about the time, just do the best things you can. You've been doing very good, just take your time, yeah? Eric. Who am I?
That's two procedure. 5 o'clock.
So what do you think the most likely diagnosis will be here?
आंटी हाथ लूज रखिए, टाइट नहीं करेंगे बॉडी को, बिल्कुल लूज रखिए.
There we go.
Two milligram of midazolam and 4 of
2 and 2.
2.
That some I've been trying to give 1 and 1, seeing how they go. I just think 2 and 2, and just let's see how we go. I think she'll be a little bit more sensitive. And the other thing is diabetics, they tend to have a bit worse bowel prep and as well, so we need to be aware of that as well. So, what do, my friend? Rima will come and help you with the PR.
मरीज पेशेंट परेशान परेशान है, सुनो इधर सुनो, वीडियो देखो, वो परेशान है लिखो. अच्छा अच्छा परेशान है, इसी से आपका मुआयना होगा, फिर ठीक है, आइए.
सबको ढीला छोड़ दीजिए. सबको ढीला छोड़िए.
So tell me what you're doing, my friend, now your tube is in.
I'm separating here.
Yep,
White liver.
yep. What talk? So where do you think the lumen is?
The lumen is at 11, 12 o'clock now.
Excellent. Okay, so just make sure your little wheel is neutralised, so it's in the 10-2 position rather than the 5-2 position. Your little wheel is at the 5-2 at the moment, so let's make sure it's at there. So the torque steering will work better now. Excellent, well done. Advance the scope nice and steady. Always make sure the little wheel is neutral. Well done. So where's the lumen? Why are you going anti-clockwise?
I'm taking the fluid at 5 o'clock.
if you can see where to go, leave the fluid where it is at the moment. So if you can see where to go, don't worry about the fluid. If you can't see where to go, then worry about the fluid. At the present moment in time, the fluid's not the... It may be if you continue to have this problem, but the thing is, if you try to aspirate this fluid now, you may encourage more fluid to descend from the right colon. Okay? If it is too much of a problem, you can take a little bit, but not too much. Excellent. So where's the lumen, my friend? About 11, now 12, yeah. Good, good. Follow the folds, 11-ish, anti-clockwise. Good, excellent. Excellent. Nice, steady progress. You okay, Rima? Happy? Is he happy?
Yeah.
Good. Take a little bit. Now that's interesting. What can we see? What can you see on the screen? Anything? Nothing? Have we seen anything?
Anything abnormal?
Untoward. Take some of the air down. Suck. Bit more. Okay. We'll show you in a minute. It'll be up here. There's two. Too small. Yeah. Two small ones. Yeah. Yeah. That's one. When the air is down, you see them better. And there, look. Draw the scope back. Can you see now?
Dr. Aslan?
Here. Well done. 5 minutes late, like, but don't worry about it. So, don't over-insufflate with diverticular. Why? My friend, this is nothing diverticular compared to the UK. This is nothing. This is baby diverticular. Yeah, this diverticular I wouldn't even get out of bed for.
Please continue. In colon.
Yeah, man. Clockwise. Don't waft. Start with your thumb at 6, bring the scope round to 12. Start with your thumb at 6, bring the scope round to 12. Good. Draw the scope back a centimetre. Big wheel forward. Now more clockwise torque. She's just moved the leg, don't worry. Clockwise torque more. Clockwise torque more. Clockwise torque more. Tip up. So big wheel back. Tip up. She just moved again. Keep the torque on. Draw the scope back. Oh, that's it. Big wheel forward, so it's neutral. That's good. Draw the scope back. Anti-clockwise. So on, off. Excellent. Now you'll start to see the lumen come into view. So come back. Just a bit more. Bit more. Come back a small amount more. Excellent. Come back a little bit more. Scope is about to shorten itself. And keep the clockwise on. Draw the scope back. Excellent. Now, keep it coming back. Keep it coming back. Tip up. Keep it on. Tip up. Okay. A little bit of anti-clockwise. Anti. There. Away you go. Advance slowly. Good. That's way too full. You're very quiet. You're very quiet.
I don't understand what
You're very quiet. Tell me what you're doing.
I'm
I know what you're doing, but tell me what you're doing.
following the link and
Yeah.
now I'm going to rotate the clock very
Excellent. Better. Tell me more. Tell me more.
just torque in the proper direction.
Yeah, where's the
Now
lumen?
with drawing to see that
Where do you think the lumen is?
lumen is at 1 o'clock.
Okay. So how are you going to bring the lumen to 12 o'clock?
By rotating in the anti-clockwise.
No, clockwise. More, more, more. Now tip up. More, tip up. Good. Tip up. Excellent. Anti-clockwise. A little bit now clockwise. More. Good. Now, there. Tip forward so you can actually see where the lumen is. It's just missing that fold. Because what's happening is, this is where the fold is, and that's what's happening. So where's the lumen?
At 4 o'clock.
Draw the scope back. Draw it back. Draw it back. Where's the lumen? So how are you going to get the scope to look at that direction?
I'll bring it to 12 o'clock.
Right, if you continue to go clockwise torque, it'll be the wrong way. If you bring the scope round in anti-clockwise, now tip up. Tip up. More anti-clockwise. Now neutral. Neutral. It's right in front of you. There you go. Now you can go for the 4 o'clock because you would have just continued to loop in. You don't need to do that. Good. Excellent. Clockwise torque. Stop. Big wheel back. Draw the big wheel back. Nice and slow. Don't advance the scope. I can see you advancing the scope.
I'm doing that.
No, don't do anything with the scope.
Okay.
Just big wheel back. Now a little bit of air. Now stop. Clockwise 5 degrees, anti-clockwise 10 degrees. Clockwise 5 degrees, anti-clockwise 10 degrees. And again.
She is feeling pen.
Okay. Tip up. And then we'll draw the scope back. Is she okay?
What need to? Other than say what? Yes, she is alright.
Okay, anti-clockwise. Good. Wait. Wait. No, you're fine. Keep your eye on this monitor. This picture is the same as this picture. So you don't need to look at this picture. Alright. I'm just thinking of a discomfort. Just put the scope down. Put it down. Go on. Put it down. Let it go. Okay, so she's uncomfortable. If we look at this, just move along a little bit. If we look at this, see the scope? See the shape we've got? It's moving around, and that's moving around because of a bowel. We just take that off. Now, if we show you this, I'm going to draw the scope back, alright? So we're drawing the scope back. Just a fraction. Take some of this air out, because the air is there. Is she okay now, Rima?
Take it? Yes, she is alright.
Alright. Now, the scope, what you're doing is your hand, see that there? That shows you you've had your hand here. So what that does, it steers the tip in the wrong direction. Your hand's gone too far forward. See, you don't need to be putting the torque on. Your hand's over here, you're making work for yourself. Keep the hand going in straight. You don't need to make work for yourself. Good. Now, where's the lumen? Don't pull it back. Look for the. I left you with the lumen. All you have to do is pick the scope up, look to your left. There you go, and there's the lumen. So you don't need to look for it when it's there in front of you. Well done. Keep the scope going in a straight. Again, you've left your hands go forward. Okay.
Don't tell him to bring it to Pakistan because it will be gone.
That's it. Slowly does it. Suck.
Why?
Have you got an empty one?
Yeah.
Have we got an empty one? Empty jug? Look, empty. Now your hand can't go forward. Okay?
This is a good idea.
Absolutely. That's diverticular. Come back. Come back. Now have a look again.
It's in 2 o'clock.
Absolutely. So, you going in and lifting the tip up is not going to take you to 2 o'clock. You need to put that lumen at 12 o'clock. She's just moved the leg, so you just need to put the tip at 12 o'clock. So rotate 90 degrees of clockwise torque.
I did that.
90 degrees of clockwise torque. Tip up, slowly. And apply a little bit more torque. More. Okay, let me just have a little look for you, my friend. I'm just seeing, let go, you're okay, let go. It's alright. If you notice, I don't worry about the scope. Oh, it mustn't move. That's fine. Right, so we draw this back. See how much scope we've got in? The tip is staying central. See it? Now I've actually brought the scope further away from that. You're using, I've put that there to stop you putting your hand forward. And you're thinking that's it, I can push up to that point. I don't want you to push up to that point at all. That's what you're going in, that's what you're causing the pain, because you're going into that lady's diverticular. Alright? I want you to come back and see where the lumen is. Where is the lumen? And you've gone too far. Okay, so it's now 10. So big wheel back. Okay, all the way back with the scope. Let the clockwise, anti-clockwise, clockwise, anti-clockwise. Come on, I'll let the scope go. And let the scope go. Clockwise, anti-clockwise. And now it's just going round. And then let the scope come back. See it? And hand is off the scope. On, off, on, off. And hand off, because I understood what she said. And this is a lady that you thought, you said, no, she can't have this. Just because they've had sections doesn't mean that they won't have issues. I'll just wait. It's going round, but I'll just wait. Hand is off the scope. There. Now wait.
To relax the ball.
All I'm doing is letting the bowel relax. Little wheel, neutral. Slowly clockwise torque. Slowly. Draw the scope back. Watch that thing there. See what it does. Anti-clockwise to steer it in a straight line. Clockwise. Draw back the scope. Draw back the scope. Tip up. Draw back the scope. I'm letting the scope relax. Draw back. And draw back again. Now it's amazing how much air there is here, even though you've put very little in. And then allow the scope to go forward. And now let it come back. And what I'm trying to do, I'm feeling how the torque feels on the scope. The scope itself wants to go forward, but it's feeling very tight. And why it's not going forward is that the scope itself wants to go through this little angle, and this is often secondary to when people have had diverticular in the UK, and the diverticular itself causes problems where the bowel becomes a little bit stiff. And we'll pop that there, but she's kicked it back at me. See the bowel? So the scope will go forward. So can she, Rima, can she come onto her back? Can she come onto her back? Yeah, can she come onto her back?
ठीक है वापस निकाल हवा निकाल
दोनों पैर को फोल्ड करें, पैर को उठाइए जरा, उठाएं, फोल्ड करें, और एक सेकंड रुक जाएं, उठाएं।
Brilliant. And this lady's got a very, very tight sigmoid. Very tight. And it's not uncommon, as with the UK people with diverticular, to have a sigmoid that's like this. So often I would then do this test with a different scope. These big scopes are very, very uncomfortable. And so what I'm doing now is just bringing back the scope, keeping the lumen central. If you look, pick up the scope, and I can actually turn the tip. The little wheel is central and the big wheel is central. I'm just now seeing where it wants to go, which is here. And this is not easy. Okay. Back again, allow the scope to go forward. And back again.
Left letter.
No, I want about the scope. I'm in, I'm out. When I took over from you, we were up to 70 centimetres before. If you remember when you had the scope, it was up to 70. Now we've reduced, but we've gone further in. If you look at the scope guide suggests that that it's straight. So we can just pass the scope ever so slowly here. I keep the torque on. And then back. and then forward.
ठीक है
And as I predicted, the prep wouldn't be that good with somebody who's a diabetic. So we just, at the moment, all I'm trying to do is get it so it's a bit more comfortable for her. We're clearing a lot of this muck. And often it's interesting, you know, when you guys do these tests, it's interesting that you'll see that people like us, even though we can fly the scope round the majority of times, when it has to, we take our time. Okay? Very important. And it's knowing when that is. That's the most important thing. Rima?
कंटिन्यू
Thank you. So the scope is just going forward, just slowly. So if we give her another one, yeah, 1 and 1,
वन कीज एंड वन का
yeah.
हाँ बस हो गया और रात की
हाथ भी हाँ इधर ही रखो आराम से आराम से आराम से अभी ठीक हो जाएगा
टेस्ट रोक दिया है तो क्या ना करेंगे इंजेक्शन
ये
लगाते
टेस्ट
हैं
नहीं कर रहे वो खड़े हैं आराम से लेके यहाँ कुछ भी नहीं हो रहा है सांस ले आराम आराम से सांस ले आराम से सांस ले
previous sections
You'll believe me next time.
yes
He didn't think that somebody with sections would have discomfort, and I says she'll be very uncomfortable. Why has she got hiccups? Why has she got hiccups?
because of the air insufflation and the diaphragm stimulation
No? Nothing to do with that? So, can she come onto a side to face this way?
in this side
Yep.
right
No.
in this side
This side, yep.
अम्मा इस साइड पे इधर शरबत लीजिए आई
Why has she got hiccups?
आई आ जाए
If it was biasplenic flector, I'd say, could be, but I'm not.
आराम से
We're in the sigmoid, so why has she got hiccups?
कमर पीछे करें और पीछे करें
It's not over distended. Anything else? What have we just given her? If you give it too quick, it causes
That's
hiccups.
I think good. Okay. खाना नहीं खा
What I'm trying to do, as you can see, trying to get it so it comes past this fold that's on the left hand side, that's just creeping into view every time. That's the fold that's stopping the scope going forward. That one, you can see just down here. That's the fold that's stopping the scope going forward. Excellent. How are we doing, Rima? How are we doing? You okay? Now, just because we're here, what I'm going to do now is just take a little bit of time just to take some of that liquid off. If we look at that, that suggests that we've got a wonderful shape in the scope now. Let the scope back, let the scope go forward. Have you noticed we've lost suction? Is the suction? Ooh, Rima. Ooh, you mucky pup. Are we full?
One minute wait.
1 minute wait. 1 minute wait. So, we brought her back onto this side, as you can see. We've got the scope to go round. If you remember what I said, to get round the sigmoid, it was a lot easier to put the person onto the right lateral, so we've traversed that part of the bowel. She's been a little bit more comfortable. I don't necessarily think it's down to the sedation, even though we'll give her a little bit more. If I was causing a discomfort like what we were doing in a left lateral and on her back, an extra 1 milligram wouldn't have touched her. So.
Suction bottle full.
Bottle, I see. Here comes Rima. She's like the cavalry.
Yes.
Wonderful. Absolutely brilliant. Thank you. Thank you. You see? We bring that round.
Absolute.
Suck. Good. 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 Have you ever scoped anybody in this position? No? No? Okay.
Continue.
Yeah? No? You never done? No?
Yes.
Yeah. Oh, you will have done, you will have done, you will have done. Suck. Yeah. Right.
Yeah, forever.
Let me show you how, not the stiffness. Let her keep her on a side. You've allowed her to come onto her back. Onto a side,
Right lateral?
onto a right lateral.
पीछे करें थोड़ा सा कमर पीछे करें कमर पीछे करें आंटी कमर पीछे करें जी थोड़ा सा और पीछे करें दोनों पैर ऐसे मोड़े मोड़े पैर
Brilliant.
मोड़ ले गुड गुड
Draw the scope back. Yeah?
Paul,
Yes, sir.
are you using the scope guide?
Oh, I forget about that stupid thing. Yes, my friend.
Thank you.
If you want me to say yes, I'll say yes.
I was just I'll let you pass through this.
No, not a problem. Talk away. You know me, I can talk for anybody.
Yeah, I know.
My friend here, he's a very quiet man. You
Who
know.
is?
Say hello.
He's a quiet man.
He's a quiet man. He's very young.
His boss doesn't allow him to talk. You see, you need to know his boss.
Well, I tell you.
I know him very well, so when he is around, you can't talk.
Oh, is that right? So your boss doesn't allow you to speak?
No, he's not loud. He's talkative.
Oh.
You are both.
Oh. Now, if you see, what I'm doing here now is just standing and admiring the weather. So the scope guide is completely all wrong. I'll show you what the shape should be. If you were actually believing the scope guide. And there you go. That's the shape of this, if you believe the scope guide. So according to the scope guide, that would suggest we're mid-transverse. If you look at the scope, you can see that it's 0, 1, 2, 3. I haven't got anything there. The little wheel's neutral, the big wheel's neutral. As I advance the scope here, I bring the scope so the buttons are pointing to the floor. And the
Bring the
scope is-
endoscopic view, please. Thank you.
So we've got down here, so the scope is now, the buttons are facing to the floor. I will draw the scope back a centimetre. Do you see how it come away? Just 1 centimetre is 1 to 1. I'm not going to do anything with the liquid. All I'm going to do is just advance towards the liquid, tip up, advance towards the liquid. There, round. So now I just suck a little bit and draw back the scope. This will then, if you actually look at the scope guide, as I come anti-clockwise and keep the tip central,
Scope guide, please.
the scope guide
Thank
will
you.
come forward with the apex of that loop. You'll see it, and then the scope will want to step forward. As the scope steps forward, and this is why I always tell people to avoid to try and suck, because then you get a deluge that comes on top of you. Now I'm going to bring the scope back up, and what we've got is one loop in the umbilical. The reason for the loop in the umbilical is that I can actually keep the torque on that I want, which is a clockwise torque, and that enables me to keep that on. It's for no other reason. I can see where I want to go into the liquid, and I just advance the scope just a touch. Point and suck. Keep the scope pointed at 12 o'clock, knowing that so it can't catch whatsoever. Keep it at 12 o'clock. Now the scope should be coming to the hepatic flexure, judging by that. So now I want to slowly do an anti-clockwise torque. As I slowly introduce an anti-clockwise torque, I pull the scope back. I now just adjust my wheels, so I keep it here, and then introduce that torque back into it. This is catching into the wires. She needs to keep her knee down. That's fine. And then we just draw this back. And now I just, again, if that's too uncomfortable, I just draw back the scope. And again, I'd let that one just come back out. And I draw back the scope. Keep it coming back, keep it coming back. And now just relax the scope. Keep it straight. Now you can see it's got a different configuration. And I'm trying a lot of the time to avoid to use the stiffness. I don't like using the stiffness. If I can avoid it, I will.
In your experience, Paul, when do you use the stiffness?
To withdraw. I only use it on withdrawal. I don't like it because a lot of people use it to advance it. Now this is again coming back to that point. I've now got no loops in the umbilical. I take it off and I put it back on. I take it off and put it back on. Lots of fluid, and I did predict that we would have a possible bad bowel prep. I also predicted to my friend here we would have possible discomfort for this test because of her previous surgical history. Even though it was C-sections, she's had multiple. So as you can see, we're on the verge of it just going round the hepatic. All I'm doing is just keeping it on, and I'm keeping the scope in a straight line. Again, just come back. I watch what it does.
Paul, at this stage, do you sometimes put the patient back on their back because you will then be straightening the thing?
I do, but I just think for her, I think the thing is just to have one go,
Okay.
just to see if it'll drop round. And I think if I draw back, and just draw back another section here, and then just I point it away from the lumen. And now I'll let it look at the lumen just to see if it will go round. And that fold, it's just not wanting to go round that fold. Can you see it? So I draw it back again. So I've got it there so it wants to look round. She's just moving her feet. And I let it look. I don't do anything, I just let it look. So that's just letting the scope look. A lot of the people tend to rush at this point, and that's what you should avoid. Now, the trick to thinking about is, what do I do next? If I was to put her back onto her side, that would be the right thing, onto her back. I'm going to just put a little bit of a clockwise torque, so I've now gone 360 degrees. 360 degrees has brought the scope up and around and through. And all it is that I'm trying to think about ways over here to maintain dignity, to be quite honest. It's not that that's what I would teach. In the UK, I would say put the person on the stomach, back up on the left lateral, and then that would then force the scope round. I'm just trying to keep her dignified. And if it doesn't work, then I'll put her onto her back and then back onto her left lateral.
Yeah, I appreciate that, Paul. Thanks.
As you can see, I'm fighting this deluge of liquid. Okay, I give in. We'll put her onto her back, darling. Now, if you look, there's not much scoping, but I'm not going to show you too much for dignity reasons. Just come onto her back nice and slow. Brilliant. And then as she goes back onto her left lateral, left side. Then one finger is holding the scope pinned to the bed. As I see her heel come off the bed, you'll see what I'll do. As soon as that, and that's it. All I do is just flick it with the hand. Now the hand is off the scope. I draw the scope back, suck, a little bit of a blue tinge, and now let the scope go forward. Up, and you can see. Now what I'm going to do again, Rima knows what I'm going to do. I look at the screen, make sure, and she said okay. So I advance the scope now. You can see. So what I was showing you yesterday on the mannequin, where right lateral to get round a difficult sigmoid, and we got round. Then we kept them on the right lateral till I couldn't go any further. Put them slowly onto the back, and then we discussed what's the best position to go around the hepatic flexure, and the hepatic flexure is on the left lateral. We now, if you look at, the scope guide's all wrong. If you look at the scope guide, that suggests that we're coming at the hepatic flexure. We've got some liquid that's just in front of us. So I'm blowing and I'm sucking intermittent. The procedure isn't making me sweat. What's making me sweat is the weather. So I keep the scope in a straight line. I'm now pointing the buttons over here. This is something that I don't teach very often. And as you can see here, this is where we want to be. I'll do the little wheel forward and then just let it come back. I don't panic, because a lot of people say, oh, the scope's falling out, do something, do nothing. Because the worst thing you can do is suddenly panic and then end up with a scope that's been rammed in. And that's what I don't want to do. Put that scope back in, put that scope back in. The scope will go back in. I've been there once, I'll get there again. Chill. So come back with the scope. I can see where it wants to go. I allow the torque to come in. Now you can see I've got nice torque ability with the scope. I'm not looking at the scope now, just for purposes. The back. Scope going now. If you look, I'm putting on and off, torque on and off, on now, on now. Scope come back. Increase torque, on, off. Now look at the wheels. Little wheel is neutral, big wheel is nearly neutral. And there, we're round. Suck, 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 draw back, suck, 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 draw back. Now, if you watch the right hand how it crawled along the scope, now advance the scope. And that is how you get round. And you're just thinking all the time, what is the right way? And point at 12 o'clock.
Well done, Paul.
Come back again, and then just see. And it's just, all the time, you're wanting to use the patient to your advantage. Get it to work its way around. Come back again. And now I can see where the IC valve is. And it's done. It wants to force itself back. With this, I tend to just put a little bit of clockwise torque. If you look, steer a little bit with the little wheel, a bit more clockwise torque, draw the scope back, suck. A little bit more clockwise torque, draw the little wheel back, and then the scope will actually sit there and then keep it on, and then you'll see it just want to say hello. There you go. And back. And that's how you get into the cecum. That's the cecal pole, bit of liquid, piece of cake, and out. So cecal pole. IC valve just below us. And that's it. Happy? That was very hard. A couple of reasons. Diverticular didn't make it hard. Diabetic, she's C-sections, but she's also a lot of places for the scope to go. That's a nice way of putting it. Okay. I have got a lot of places for the scope to go. Saad, if anyone ever got hold of Saad to scope, he's very easy. He's a very slim man. Now you're going to go stare at him, aren't you? I can tell. And there. Okay. Happy? Right. Now Saad's going to ask which is the optimal position to get in the terminal ileum. My answer to that is any position you can, you should try them all. So any position, the optimal position is the one that works.
7 o'clock.
No, the best position to have the patient in to get into the IC valve is the one that works. Doesn't matter if it's at 7 o'clock, doesn't matter if it's at 9 o'clock, doesn't matter if it's at 12 o'clock, it's the one that works. If you look now, you'll see what I'm going to do is just turn in here. So we just turn in, step back, appendix. So we just use the scope to force it to one side to bend. Let the scope now come back to here. We're right on the lips of the eye. Let that go. Bit of water, let the water come. Clockwise torque, knowing that where it wants to go, and that's that. All yours, my friend. He's done. Happy? And now when you see that shape on the scope guide, you wonder what all the... Look to your right, look to your right. Ooh. You see how much it drops back? But we've been there, so I'm reasonably happy. So the history, what was the history, my friend? Can you... What was the history? Okay, so we've got a little bit of constipation, which would be okay with diabetes. We've got fresh PR bleeding, so we've not got a problem. Stool that we've seen is normal colour. Excellent. And now come back nice and slow. Come back nice and slow. 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 Quick. Slow. Thank you. Slow. Slow. Thank you.
Once I've got the scope moving and I have a patient in supine position, I don't have to change anything. You don't have to unnecessarily move, but if it's an uncomfortable position for you, then once you pass the negotiated the thing that you wanted to, just bring them back to a position that you're comfortable. Very important to look after yourself also. What's the problem? where there's going to be less endoscopy, है ना?
endoscopy बहुत ऐसे हैं,
नहीं करते तो नहीं है ना फिर यार.
लेकिन limited procedures. They are only limited to
What I mean, I'm not saying patients नहीं, I'm saying जो procedures होते हैं वो फिर fellows के लिए तो enough नहीं होंगे. But procedure है
number of
लेकिन अगर
procedures
आप
बहुत है. Number of procedures patients बहुत.
what I mean, you know what I mean. It's not
वो
about
नहीं
numbers.
what you are
It's
that
not
is
numbers. It's not about numbers. You do 5 colonoscopies, 10 colonoscopies, and numbers is everything. That's you run some basics and then you build up.
old school
Multan,
techniques.
Faisalabad, or Sialkot. Sialkot, somebody came last time to our course. Aisha?
He's the one who sent us. Like he was after us to go do it.
Do you remember Dr. Qasim there?
That's the tall guy.
Last year from Sialkot. I can't place. But it's more gray. But I remember somebody coming from Sialkot. ये मुझे याद है because I Sialkot because we were one of the criteria for selection in our course, whichever one. The moment we find out a location that we know does not have, then you are automatically. Then we are very excited. We know जहाँ पे training अच्छी है और भी वहाँ पे जाए.
पहले से में good problem because we did not have the equipment.
अभी आपने क्या करेंगे?
We took me 8 months to buy almost everything.
Not bad. You bought the 190.
We have this is a 170s and the scopes are 180s.
This is 170. That's very good.
And we're just done with the footprint buying. Now I want to start a database, a proper.
And आपने C-arm लिया है फ्लोरा
From our floor.
फ्लोरो नहीं फ्लोरो.
Taking some old model.
So that's with the radiology or that's with your?
No, that is in-house.
You got a fluoro in your own